The BTK, the IN.PACT BTK randomized study, it's a study that tests the effectiveness and safety of a new drug-coated balloon from Medtronic, the IN.PACT 014 DCB. And the story tells that many years ago, in 2013, the previous balloon, it was the Amphibian IN.PACT 014, failed in the IN.PACT DEEP study to show efficacy. And on the other hand, there was a trend toward a worse clinical outcome, an increased major amputation rate in the group of drug-coated balloon compared to POBA. So Medtronic had to produce another study, another evidence to test their drug-coated platform, the 3.5 microgram per square millimeter, and they made this new drug-coated balloon. So this study tested if this balloon has more efficacy than simple angioplasty in the treatment of below the knee artery. But that comes a point, we design a study which is unique, because the study includes the worst clinical scenario in BTK, so long chronic total occlusion arteries in patients with critical limb ischemia. But this is just to test this device in the real world scenario. You could test a device in a simple stenosis lesion like they did with the IN.PACT DEEP, but they failed because if you have to treat a simple lesion, maybe simple lesion can be dilated with simple angioplasty and stay open. While if you start to face a complex scenario like CTOs and long CTOs, then at the end, if your device is good and has efficacy, then it will come for sure compared to the simple angioplasty. And that was the first, the type of patients we had to enroll. So patients with long chronic total occlusions in below the knee. And the second point is how can we settle the procedure in these kind of patients with thinking to have the same result in all the centers. Everybody says that it does below the knee, but at the end, I see that a few centers may provide a good quality below the knee intervention. So we had to put a limitation, and we introduced the concept of optimal balloon angioplasty before randomization to DCB or PTA. And this optimal balloon angioplasty is not defined only by the angiographic outcome. I mean, a stenosis less than 30% by visual estimation, which is not so a good quality point, but we introduced the duplex ultrasound and the scanning for all the treated segment of the duplex and searching for an increased velocity of the flow, that means a residual stenosis, and a flow pattern, trying to reach the best biphasic or triphasic flow. This was the concept of the study. So a new drug-coated balloon, a new procedural aspects of this study, but also how did we measure the outcome? Because measuring the outcome with restenosis in BTK is not the proper parameter we want to know. And also with the late luminal loss measured as in the coronary artery, where the lesion is like 20 millimeter compared to 180 or 200 millimeters in BTK, the focal point of restenosis or late luminal loss is not so interesting. So we added to this study another concept, which is the subsegmental late luminal loss. So we take the entire segment, which is occluded or stenotic, and we divide this segment in 10 subsegments. In each of these subsegments, we measure the late luminal loss. So at the end, we have a very precious information regarding the longitudinal loss after DCB or after balloon angioplasty. So the findings, we have to add that for the study design, this is a feasibility study. And the feasibility study, you don't have a statistical hypothesis, but you are searching for just to see if you have one signaling that tells you that the DCB is better than POBA, because Medtronic was afraid to make another mistake after the IN.PACT DEEP, to have something going wrong. So before planning a big trial with hundreds of patients, we had to test this balloon and see if, from an angiographic point of view, this balloon will add efficacy. And so this is the point. The primary endpoint of this study, it was the late luminal loss, and we calculated the late luminal loss according to the classic system, the classic model, the focal point, and the subsegmental method. And this is for the angiographic evidence of lower late luminal loss in DCB patients. But then we have also to face the other problem that came out from the IN.PACT DEEP study. I mean, the balloon has to be safe. So major amputation, and procedural or device-related death and target lesion revascularization were the second endpoints of this study. Then when we went to 9 months angiography, we had to see that there was a very impressive reduction of the longitudinal late luminal loss, going from 1.26 to 0.5. So the drug-coated balloon was really efficacious in reducing subsegmental late luminal loss. But also from the standard, the classic late luminal loss calculation, we have a reduction from 1.3 to 0.89, which is only a trend statistically significant, 0.07. But this is due only to 49 lesions enrolled. I mean, if you start to calculate in 100 or hundreds of patients, you will have a very significant difference also in the focal, in the classic late luminal loss measurement. And at the end, this is where the positive result, so very good in reducing restenosis and intima hyperplasia, reducing the loss of the vessel, but also the other information that we had 0 major amputation in both arms. And also we have a very low mortality in DCB treated patients. So the half of the mortality, 4.0 versus 8.0 in PTA group. So that was the second positive news that came out from the study. And again, in the IN.PACT DEEP, in the first study with another device, there was a trend for a major amputation increase using the drug-coated balloon. But that was totally another story. The conclusion of this study is that first, all the data that came from the past are not is not responsible only the drug-eluting balloon technology. Of course, for the efficacy, this new balloon that is following the same technology of the IN.PACT use in the SFA trial, is of course is better than the previous one. But also it is important to understand the algorithm of the CLI patients treatment. I mean, in this study, we added the fact that should be a wound care program for these patients. So we had 0 amputation in both arms. And also the clinically driven target lesion revascularization was real clinically driven. I mean, a restenosis reocclusion with a wound or with symptoms. So it's for sure a positive outcome. And also the design of the study can give more to future studies of BTK and to plan new algorithms of treatment. Well, I mean, the paclitaxel controversy is like a nightmare. Then a nightmare stop when you wake up. And I think we woke up because all the story of increased mortality was confirmed by no studies, no other studies. And in adjunction, there is a publication from Professor Zeller, infrapopliteal artery, that showed that at 5 years in real world scenario, paclitaxel treated patients have a lower mortality compared to angioplasty patients. And also our center did a very nice review, and was a case control match study in 7 years of follow-up, we show that in critical limb ischemia with a below-the-knee treatment, paclitaxel-coated balloon are linked to a better survival than a PTA. And this better survival is statistically significant up to 5 years. Then it tend to disappear at 7 years, but this because of the natural history of this disease and because of the age of the patients. The mean age was about 73, 74. So after 7 years, you become 80, and the chance that you have to die are quite significant, are not less. The problem is that when you face a disease, when you face below the knee intervention, you are facing critical limb ischemia, and there is no possibility that simple lesion may cause critical limb ischemia, simple lesion of below the knee arteries. Normally, patients with below the knee arteries disease and critical limb ischemia, they have multiple occlusions, long occlusions. So if I see these studies that are treating 20 or 30 millimeter lesions with stents, I mean, this situation are not a real world. We need devices that can change the real scenario that we face every day. And according to the fact that all these patients have long lesions, and also it's coming up that all these lesions involve also the BTA artery, the below the ankle artery, I think that DCB is really important because it's the only device that best match the need for this anatomical scenario.